about 15 seconds. Let's begin. So good day and welcome to this Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us for this seminar. I'd like to welcome our web viewers and the Ontario Telehealth Network sites. This seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to after the seminar presentation so that we can get a microphone to you. For our virtual audience, please send in your questions and we will ask them for you. A very warm welcome to our guest speaker, Dr. Carolyn McGregor. I'll introduce Carolyn more fully in a moment. These seminars are hosted by the Waterloo Institute for Health Informatics Research, the Lawson Health Research Institute, and the National Institutes for Health Informatics. I'd like to acknowledge our seminar series sponsors, Borden Ladner Gervais, McKesson, and Healthcare Information Management and Communications Canada. Without these sponsors, we could not host these seminars, and we're very grateful for their support. I'd also like to thank the IEEE EMBS for providing the refreshments today. I think we're all enjoying them. So I'm sorry to the virtual audience, we couldn't get them to you. I'd like to just have a couple of minutes for announcements. Our next Smarter Health Seminar will be on Wednesday, June 24th. We hope that you'll come back and join us that day. As well, we're offering a Health Informatics Boot Camp at the University of Waterloo from Wednesday, June 17th to Friday, June 19th. You can still register for this boot camp at our website, hi.uwaterloo.ca. The Smarter Health seminars this past few months have been focused on the health informatics and the e-health industry and HI as a profession. The schedule for today is as follows. Carolyn will speak for about 45 to 50 minutes. This will be followed by a facilitated discussion. We would welcome your questions and comments during that time. As I mentioned, we'll ask you to hold your questions to after the presentation. Please signal to me or my colleague, Amelia, where she is, and we'll get a mic to you. And we invite web and teleconference viewers to send in their questions and we'll ask them for you. We are very delighted to have with us today Dr. Carolyn McGregor. She is an associate professor at the University of Ontario Institute of Technology with cross appointments with the Faculty of Business and Information Technology and the Faculty of Health Sciences. She holds a Canada Research Chair in Health Informatics. She received her PhD in Computer Science at UTS in Sydney, Australia. Her PhD research included an innovative intelligent decision support system framework. This led to further pioneering research in the areas of web services, event stream processing, multi-agent data mining, and near real-time data warehouse loading. Her recent research focus has been to improve and extend this research within the context of health and medicine to create advanced support for clinical management, and to create new remote patient care frameworks, patient journaling, modeling, and re-engineering approaches. Well, you can imagine why she received this. In 2008, she received the prestigious multi-million-dollar IBM First-of-a-Kind Research Award given by IBM Canada and the IBM T.J. Watson Research Center in New York. I look forward to Carolyn's presentation today on neonatal health informatics, Uncharted discovery, and please welcome Dr. Carolyn McGregor.
Thank you very much. And thank you for the opportunity to share with you my research journey and some of the innovative research that I'm working on with my team now at UOIT. So today, I'm going to introduce a little bit about the research work that I began during my PhD and how that was established based on my industry experience with a number of corporations within Australia. And then moving on to the neonatal environment that I became involved with around 1999, and how the synergies between what I'd learnt with data analysis for finance, business and retail was naturally an area that I could apply into critical care and specifically for neonatal care. So I'm going to introduce you, if you're not familiar, to the world of neonatal care with some examples from around the world, and then I'm going to introduce some of the research projects initially started in Australia, the Simulated Remote Neonatal Intensive Care Unit, the Service of Critical Care Model for Intelligent Patient Monitoring, the IBM first-of-a-kind collaboration that I have, which is codenamed Project Artemis, and then speak about some other research trends that we are looking at to try and change the way that we utilise computing and IT support within neonatal intensive care, and how we can learn from physiological data and have that have a direct impact on patient care. I'll just introduce also who we're collaborating with and provide a little bit of information about the unique laboratory that we've been able to establish as part of my Canada Research Chair at UOIT. I'll conclude this presentation with a very brief summary about Engineering in Medicine and Biology Society, and also broadly the IEEE organisation and their Women in Engineering initiative, because for 2009 through 2011 I am the Canadian representative for the Engineering in Medicine and Biology Society, and I'm also their inaugural representative for Women in Engineering internationally. So I wanted to just give you some information about those particular initiatives. So first of all, moving on. My initial PhD research stemmed from a need that I could see within industry in banking and finance and retail within Australia and internationally. I graduated from my bachelor's degree and was asked to become involved in a new and growing area known as executive information systems. So as we put it at the time, putting computers in Mahogany Row. One of the first challenges that we faced was that there were no Ethernet ports traditionally put into general managers' offices. And then from there we needed to establish the very first executive information systems so that the general or the managing director of a financial institution could find out about opens and closures of accounts and deposits and withdrawals on a daily basis. I then was asked to establish a similar system within the largest retail chain in Australia, where we were looking at starting to assess buying analysis of customers within this grocery retail chain. What I started to see in that environment was that there was a need for the strategy to drive the way they went about their business through business process definition. And I'm not going to dwell a lot on this today because a lot of it's outside of the scope of the presentation today. But then we needed to take a strategy to drive the way we carry out our business, how we're enacting that workflow when we're actually carrying out the work of our business, and collecting a lot of that information within a decision support environment. So that was the basis of my PhD, and linking all of those areas together. But one of the things that started to become apparent was the growth in this data mining area, and the need in this instance initially that we were looking at customer clustering and supplier clustering and behaviour models. And I also introduced a mechanism to create a decision support system that you could interact with via a series of web services, promoting that service-oriented architecture approach. So one of the things that we were able to create for that particular decision support system was to be able to have a web service interfaced environment where you could initially set the structure up for your organisation of the processes, that you'd have a series of events coming through from the different sales or deposits and withdrawals of the organisation that could be analysed by this event stream processor, and that the data would be stored, and that you would have this analytical processor that could analyse the historic data. Now at this point you may well be saying that, okay, if we can set up this intelligent decision support system environment and it has these various strengths and techniques to support retail and banking and finance, then we talk about neonatology and how do the two worlds start to collide. Well, one of the things that I hope you come away from for this talk today is that the problem of critical care health informatics is largely a similar problem to a lot of the sensor-based work that is done for a lot of the other industries. So I now want to spend a little bit of time describing what neonatal care and neonatology is, and then we can take a step back and say, knowing that I had this very rich skill set of working with streams of data and analysing data stored in data warehouses, how I can take those skills to change the way neonatology is carried out around the world. So let's take a little step back and think about neonatal care. In Canada, you may not know this, but 1 in 14 babies are born premature. Approximately 17% of babies born in New South Wales, Australia require some form of care. 15% of those need to be transported. The statistics are actually very similar between Australia and Canada. In China, the babies are 9 times more likely to die prematurely in remote areas than in the urban areas. In Canada and Australia, it's about a 2-to-1 ratio. The head and torso of a very premature baby fits in an adult male's hand. The lungs are not developed in a baby until 37 out of the 40 weeks of gestation. So if that baby is born before 37 weeks, their lungs are not mature. There are techniques they can use by giving the baby steroids before birth to try and mature the lungs, but still you have a series of immature organs. So these babies of a 40-week gestation can be born 17 weeks early, 4 months early, and they can weigh only 450 grams and fitting inside an adult male's hand. They will spend 3 to 4 months in a NIC unit. If they develop nosocomial infection, which a quarter of them will, they'll spend twice the amount of time in that NIC unit. And these are similar types of statistics. Canada has one of the, better outcomes in terms of premature birth than some of the other countries, but this is the type of environment that it is. This is the environment by which neonatologists try to interact with technology and try to gather as much information that they can about the particular patient to make clinical judgments. There are multiple devices that are attached to a baby. In the case of a very premature baby, it's not uncommon that there are 16 parallel streams of information. This data can be a reading a second or can be 1,000 readings a second in the case of an ECG heart signal. The devices themselves, you can see them all around this particular incubator. The baby in here is possibly about 27 weeks gestation. There is a multi-mode monitor here that's showing ECG signal and some other signals as well, and a range of different ventilators and other pumps, medication pumps that are attached to the baby. A range of different medical devices. From this environment, nursing staff, residents, neonatologists make their judgments and assessments about how to support this baby to grow, to have their organs develop, for them to get stronger, for them to move forward. Within this environment, as I said, multiple readings every second, and current clinical practice is to record indicative readings of each of the streams 30 or 60 minutes, at 30 or 60 minute intervals. So one reading or a trend reading every 30 to 60 minutes. So you have something that's emanating data at 1,000 readings a second to produce an ECG beat-to-beat signal, and that is generating a heartbeat rate per minute as well. And that sort of information is summarised to a reading every 30 minutes. Blood oxygen saturation, again, summarised to a reading every 30 or 60 minutes. So there is an enormous amount of data loss within this environment. All of these devices have the mechanism to display the information on their own screens. Some, in fact, most these days of the devices have the ability to output data, but it's in their own proprietary format, usually through an RS-232 serial port, sometimes these days through an Ethernet port, and sometimes still the devices that the hospitals are purchasing don't have a mechanism at all to output the data. To care for a baby, very premature, the cost of care is approximately $100,000 to $150,000. Now that is not including if the baby is overventilated develops retinopathy of prematurity, goes blind, and the constant care moving on through their life in support of their blindness. There are also studies now that are showing that there is an increased possibility of ADHD with premature children and a number of other behavioural and other disabilities that these children can develop. So the cost of care goes well beyond just their initial stay in the NIC unit, potentially. Of these children, 20 years ago, in that very early 23 to 24 week gestation period, 90% were not surviving. Now, 90% are surviving, but now we have issues to do with other developmental or other disabilities that they may have throughout their lives. So it's not only a motivation for us to try and save more lives for babies that don't have terminal congenital abnormalities, but to also improve the quality of life for those children and for their families. So this shows you a diagram of indicatively the sorts of things that are attached to these very tiny babies who incidentally have immature skin as well. So they're usually on a ventilator to assist with their breathing. They are fed data through they're fed through a feeding tube. They have an oxygen saturation monitor to monitor the oxygen levels in the blood. They're on an IV pump. They have an umbilical artery catheter, an IV pump, an ECG and a blood pressure monitor, as well as a temperature monitor in that environment. There is a lot of things that can be connected to this baby. There's some work that's being done on some bonnets that can be made so that you just put a wireless bonnet onto the baby's head so you can also capture EEG signals. But there's also leads potentially for EEG. So it's a lot that's being done with this tiny baby to try and capture the information to support and watch them grow. But this is what the environment looks like. Because it's not just one bed per bay. You have a situation where there are multiple beds, usually about 6, with all of the devices. And this is the environment that clinicians are asked to make their judgments and assessments, analysing as much of the data as they're receiving. So, knowing that I had this background of working with a whole lot of streams of data that was in actual fact a lot slower and less complex than neonatal ICU data, how could I take what I knew in terms of creating an environment to analyse in real time and historically this data and apply it within this domain? So what I started to work on was an environment where instead of ingesting business events for the event stream processor, we took in clinical data such as the gestational age of the baby and the gestational weight, any pre-existing conditions. And we also took on board the physiological data for the babies and then used that information to create an environment that we could be analysing that based on evidence-based medicine practices and clinical rules that we could establish. So how could we create this environment? Because there had been some work performed to say that let's take a particular diagnosis, or let's watch a particular stream, or let's do it for a particular patient, but nothing in the way that you could create a multidimensional environment that was flexible for multiple patients, watching for multiple diagnoses across multiple and utilising multiple streams, because you could have trends in 2 or 3 or more streams that you're looking for as a composite for a certain condition. One of the other areas that I was looking at, in addition to trying to provide an environment for real-time support for clinical research, one of the other areas that you need to consider for neonatal care is that there are a number of the patients who need to be transported. They will try and move a woman before she gives birth, but sometimes that's not possible. So they'll need to transport the baby afterwards. Now, what happens in those situations is the same in Canada as Australia and in a lot of areas around the world, or all areas around the world that provide transport mechanisms. The Hospital of Sick Children has a transport team who coordinates for a certain area of Ontario all the transports for these premature babies. So they will receive a call from Pond Inlet, Baffin Island, to say that they have a woman labouring, she's going to deliver a baby at 23 weeks gestation. At that point, they will then have the on-call neonatologist for the transport team start to speak with either the obstetrician or the paediatrician at Pond Inlet at Baffin Island and talk them through and understand and try and gather as much information clinically and support them as much as they can until the transport team can arrive on a Learjet to then go and extract that baby and bring them back to the Hospital of Sick Children or to perhaps another NICU if they don't need to go to the level of the Hospital of Sick Children NICU. So it's all done via telephone exchange. They cannot see any X-ray images of organ development. They have no information about colour of skin, about general motility, and they have no information other than what they're being described about what's coming from any physiological monitors. And in many cases, that's the information that the neonatologists need to make their general assessments and to provide support. When the babies leave an NICU, they're typically between 2.5 and 3 kilos. And even at this very reduced collection rate of summarising data just every 30 or 60 minutes, their notes usually still weigh in excess of 6 kilos. So they already have a medical record that's twice their own weight. Clinicians and paediatricians often carry PDAs, but they're not linked in to, and they're really supporting their clinical management function. So you have them buried in paper. You have the babies connected to various devices that aren't going anywhere, X-ray images that aren't integrated, and a clinical database as well that is separate from this other environment. Now, some hospitals have been able to implement a an electronic health record, but that does not include physiological data other than perhaps a reading every minute or the reading every half hour, because they haven't got the infrastructure and there hasn't been leadership in an infrastructure for this physiological data collection. Just a little bit about geography and some of the challenges that are faced. In Australia, we have approximately 20 million people. Most of the people in Australia live in a belt between Brisbane and Melbourne on the coast, on the eastern coast of Australia. 10% of the whole nation's population lives in a very tiny little belt just here, pretty much around where that E is on Sydney. Western Sydney. That's where 10% of the population is. So we have these vast areas in Australia that are very sparsely populated. And I'll give you another example to do with Aboriginal women and women in remote areas that we've been involved in as well as part of this holistic view. So there's these vast areas of remote population. In New South Wales, just zooming in, so I'm going to... Sorry, I should have gone in. So this state here, New South Wales, is the most heavily populated state in Australia. So in New South Wales, there are 2 children's hospitals and there are 8 level 3 NIC units. So they have neonatologists in them. So of those units, they are all placed, there's one in Newcastle, there's only one in Wollongong, and the rest are in a belt that is probably in this arc here, out to the S of Blue Mountains, where the Nepean Hospital one is the furthermost east. So they're all in this bracket here. So you start again to see these issues with tyrannies of distance that we deal with in Australia. So one of the initial projects that we were looking at was to try, and the basis for my work was initially to create the environment to collect the data. So whether it is out in a remote hospital, in a level 3 referral hospital, or in a level 4 children's hospital, to create the environment, because they're all by and large using the same medical devices. There are some that are common, some that are a rarity between them. But there is, for example, a Philips component monitoring system that is often used to measure the heart rate and some of the other more common measures that are in use. And we needed to create an environment so that we could collect the data from these different devices, and also a ventilator. The BabyLog 8000 by Dragar is the most commonly used one internationally to ventilate very premature babies. So initially our work was just working with those 2 devices and looking at how we could support remote care and how we could also enrich the experience within the neonatal intensive care units. So we were fortunate in receiving funding from, I guess, the Bell equivalent in Australia, which is Telstra, to prototype what we call the Bush Babies on Broadband project. And it's probably out of date to say it now, but sometimes I used to have to say this isn't after President Bush, this is after the Australian Bush, for the remote areas, the reason we named the project. So we were creating an environment where we could collect data from a remote area and allow a clinician to access either from within their hospital or outside, if they were the one on call, information. And rather ironically, the very day that our funding was received and announced, at 2 a.m. that morning, our collaborating neonatologist was on call. He had a phone call from the hospital we were planning to trial this with a woman who presented at 23 weeks gestation, and he'd spent the next few hours on the telephone supporting them until the transport team arrived. So this is what we initially built to go into the remote hospital. We had a trolley because in these areas often the real estate, the space available in a special care nursery in these remote hospitals is quite limited. So you've got this trolley with the computing equipment located underneath. This screen works as a reverse image so that the neonatologist can be seen by the parents or by the clinicians in the remote setting. There's a video camera mounted at the top of the trolley and a still camera mounted below with a light panel so that they can either put clinical notes or they can collect the X-ray images if that panel is lit, and take photos of them and send it through. So this trolley took place of the data collection unit and this remote station. In Australia, similarly to Canada, the transport was coordinated by a particular entity, and so we provided a facility using a service-oriented architecture approach. We provided a facility so that a remote hospital could request, could make themselves known to the fact that they had a premature baby, and the coordination of which neonatal unit they would speak to was then coordinated through this control centre. And then whichever neonatologist were chosen, they would then receive a message, log in and start receiving the information. So this was our initial prototype screen of that work. So you have a range of different physiological data values coming through in a waveform. This was my collaborating neonatologist in Australia, Dr. Mark Tracy, and we've purposely zoomed this image out for privacy, but this allows you to zoom an image in and they can look at skin colour and general motility of the baby, because that also gives an indication, together with the other information, of viability of surviving the transport. There's also some photos uploaded from a number of different babies, just for the exercise of showing that you can upload the images. So we prototyped that environment. Just briefly, I've also completed some work using the service-oriented architecture approach to have a web service used to receive the physiological data, because there is no standard for physiological data transmission, and often people will say to me, oh, but there is a standard, and for several times of giving the presentation, someone would say a very different standard, whether it was IEEE's 11073 or a plethora of other standards. There really isn't a standard, certainly in Canada to date, for sending physiological data, and there's not one in Australia and there's not one in the US. So this is just an example of when you encode the patient ID device, a given time, a code name and what the reading is, you can start to see that by encoding it in XML, it becomes extremely verbose. You take something in bold here, that's a small amount of data to be sent, and you wrap it in something that makes it very large. Just by way of examples of some of our work as well, working on this service-oriented architecture approach and working with this transport scenario, we have developed the architecture for a service-oriented approach for transport to be able to take those physiological reading, the sending of the physiological data, the initial request to say that you needed to speak to a neonatologist about a particular baby, and arranging for transfer and discharge, and sending any clinical notes that need to go with the baby. One of the other things that I started to look at with my research was trying to understand what was occurring in intensive care unit research in general, and particularly looking at this issue of mobility. And one of the striking things that I found when I performed this assessment a couple of years back was that that the concept of mobility wasn't part of the mandate of the research effort. There was a lot of work on trying to create intelligent alarms on individual streams for individual patients, but there wasn't a concept within that the neonatologist could be anywhere other than, or the intensivist could be anywhere other than right beside the patient or at the control centre or maybe just in the hospital. So the patient was always located in their ICU, and in fact the clinician was always located within the hospital. Now, if we're going to start to change practices, then any type of intensivist-based informatics research has to start to look at this paradigm of where the clinician is and where the patient is. Because in the case of neonatology, the patient is engaged when they first contact that neonatologist. So they are providing that support. And how do we facilitate the data exchange for that? As part of our research, we were looking at ways that people work. And we were looking at how clinicians, or neonatologists in particular, need to walk away from the units when they'll travel to attend a conference. So I had the opportunity to test our environment while I was presenting at a conference in Hong Kong. And so I was able to simulate, I had the client-based software on my laptop, or it was largely just accessing it from a web browser. And then we were fortunate to receive some devices on loan that we put in our laboratory, ran them in demonstration mode because it was awkward logistically and for privacy reasons to connect into the hospital's network. Excuse me, but we were able to run these devices in demonstration mode, and I was able to mimic what it would be like for a neonatologist. And we were able to prove that of the 4,000 packets of data that were sent within this particular environment, that all of them were received, but some of them were just out of order. Now, as a computing scientist, many might say, well, yeah, of course, you would receive that. But it wasn't so much an exercise just in computing science to test if I was on a wireless network, would I receive all the data, but was to demonstrate within clinical practice that this was a realistic, viable option to do clinical care, because they were receiving all the packets, they were receiving all the ECG signals, they were receiving all of the blood oxygen saturation. So this was a viable approach moving forward of changing clinical practice. Now, then I moved to Canada in 2007. Just again, by virtue of geography, I've scaled these two maps so you can sort of see the tyranny of distance issues we had in Australia, and here is Canada. And while Australia is about the same size as the continental US, I'm told many times it's not the same size as Canada, which is true. So we have these tyranny of distance issues. So here is Pond Inlet, Baffin Island, a 7-hour Learjet ride to go and extract a baby. So we have some challenges in distance. And this, in fact, is another neonatologist that I'm collaborating with. Dr. Robin Walker is located at Dalhousie in Halifax, formerly headed the Children's Hospital of Eastern Ontario NICU. And here he was showing in his diagram, when he gave a presentation previously when he presented at my university in Australia, that the distance from Ottawa, who coordinates the extractions from Pond Inlet, that distance is the same distance to their sister hospital in the far south of Mexico. So that gives you an idea of the distances. So now a little bit about the NICU that I'm collaborating with, in addition now, actually 2 other NICUs that I'm working with. First of all, the Hospital of Sick Children, otherwise known as Sick Kids. So this is some of the diagrams taken from the Sick Kids environment. So as you can see, number of patients, some in open bay incubators, some enclosed, but again, busy environment, lots of devices, medications, and then parents coming into this environment as well. Within this environment, it's not just premature babies that are cared for. They represent about half. There are also term babies, which are often forgotten, with respiratory problems, neurological problems, cardiac problems, perhaps congenital abnormalities, in addition to the premature babies, who have by and large respiratory problems, but also a range of other issues as well. So that's the cohort that they take care of, and they currently have 46 beds or 46 bays available. And these are the people that work there. You have the baby in the middle, the neonatologists, surgeons, residents and fellows, pharmacy, dietary, the chaplain, palliative care, rehab, social workers, the respiratory therapists, the interpreters, the ward class, the lactation consultants, and the list goes on. These are the people actively coming into the environment and providing the support. And by and large, in most NICUs, the communication between all of these people is a verbal exchange or a piece of paper. And going back to physiological data, there is limited assessment across all of these areas of the physiological data. So here's another neonatologist. This is Dr. Andrew James. We're in the Hospital for Sick Children's NICU, and he's joined our collaborative team as one of the neonatologists. Now, I put this one up before. This is the diagram of the Rhode Island bays as they currently are. They have an 80-bed NICU. And they are starting to look at this model of having multiple babies within the one room and assessing the impact on neurological development of being in this sort of environment. They've received funding to move to this model. There's one baby per room. Behind here, this is a mock-up of the room. Behind here is a parents' area. This is a pull-out double bed, or it will be, it's not shown in the diagram. Private screening area, individual fridge for the individual feeding for that particular baby. And the way that they've designed it, a nurse can sit outside in an alcove and be looking in on two babies because they're right there in front of them, but they have the space. So we're starting to collaborate with this group in Rhode Island to start to do the work in analysing the physiological signals in the current environment and when they move to the new environment, and the difference that we can detect by the different environments and the interaction that occurs within rounds, when a team is doing rounds for all of the babies in that particular bay, and how it impacts all the bays, for example, compared to this new model. This is what the NIC unit looks like that's being built. And I walked through this back in December of last year. So all of this orange bricked area, this whole orange bricked area, is the new 80-room NICU that they have. It's quite impressive. These are family areas, because while it still maintains the practice of being an NICU where children aren't allowed in the environment, only 2 adults at a time, they're still going to have an environment away from the neonatal patients where you can have the children there. So the first and second floor, or the ground floor, is commercial and conferencing space. The first and second floor both have 80 NICU beds each, and the top floor is for antenatal care for the mothers in some instances. So these are the different problem domains that we're starting to become involved in. Neonatology, as I said, is complex. On this particular diagram, I have intentionally taken off the indicators of what each of the streams are. No doubt clinicians from this domain can probably hypothesise what the different streams are. And if you asked a neonatologist to come in at any time and look at the information in this format, they would be able to make assessments about a baby's condition and recommend a course of action, certainly if the baby was becoming unstable. We also do know, though, that some research into decision-making and pattern recognition shows that the human brain has trouble going above 7 streams or 7 different inputs of information. And we clearly have more than 7 in this particular scenario. But nonetheless, if presented in this fashion, if presented in this fashion, they would be able to make some clinical assessments. But it's not presented like this, it's presented like this. And hence our challenge. So we have been working on a number of different clinical rules with the neonatologists. This is a new area, trying to determine the rules of what physiological, or the way physiological stream behaviour is represented prior to the onset of certain conditions is a new domain. One of the rules that we've been looking at is how blood pressure, together with blood oxygen saturation, is an indicator that a baby is going to become unstable and potentially crash. So this is a clinically significant event. So one of the more simpler rules that we have been looking at in our research when we're setting up this environment, doing our assessments in real time, is to take, believe it or not, if the mean blood pressure is below the number that is the equivalent of their gestational age. So if they were born at 23 weeks gestation and it's a week later, so they are now currently 24 weeks gestation, then if the blood pressure falls below that level for 20 seconds, it's clinically relevant. At all gestations, if the oxygen saturation, peripheral oxygen saturation, falls below 85% for more than 20 seconds, that also is clinically relevant. And in fact, the two combined have a strong clinical relevance. So this is part of an exploration of using this to do with frequency of dips and depth of dips as an indicator for instability in neonates. It's an interesting rule that it's based on how old they are, and that becomes a number. And in reality, there's a lot of rules like that used in healthcare in general. So we've been doing some work on a technique called temporal abstraction, where you start to look for the behaviours in the streams rather than looking at the actual numbers in the streams. So a temporal abstraction rule can consist of a conjunctive clause of the mean blood pressure falling below 24, below the level of 24 for 20 seconds, and the blood oxygen saturation falling below 85%. And we've been doing some initial testing with that. We're also starting to work now on extending some research around nosocomial infection, sepsis, which is a type of blood poisoning. And there's been some early work to suggest that the heart rate variability starts to have a certain behaviour up to 24 hours before traditional clinical markers show the potential that the baby has nosocomial infection. So potentially, within that one example alone, we can start to detect these illnesses much earlier. If you can detect nosocomial infection earlier, you have less impact on organs and potentially a shorter recovery time. So this is one of the things that we're looking at. And the early research has been through some clinical research within this environment. A little bit of information about Canada Health Infoway. Excuse me. If you're not aware, here is the electronic health infrastructure that's being established through Canada Health Infoway. So there's one of these infrastructures in each province. Quebecois and Ontario have two because of their size. And so a range of different healthcare providers can maintain their own electronic health record system, but they're required to push information up through the HILE and into their local store in this infrastructure. And then if you want to view, if I go out to Vancouver and see a doctor there and then I come back, my local clinician can use this electronic health record viewer to go to all the different infrastructures and gather any records related to me and bring them back. One of the issues with this current structure is that it doesn't cater for physiological data. The only way that it caters for physiological data at present is if, for example, you have a stress test and an ECG segment is taken as part of that stress test. That segment is bolted to the ECG results and goes into that record. It doesn't exist in its own right. And they use a particular standard called DICOM usually to try to do that connectivity on. But there is no standard when you have a neonatal patient that you have several months worth of continual physiological data that you want to be able to store for clinical research for that patient record. Its structure's not there. I have, and one of my colleagues started to work with Canada Health Infoway and their standards committee to try and establish this, and it's their mandate and hope that in the next 8 months that we will have established the standard within the structure for the way that physiological data will be transmitted and also stored. So this is just a diagram here of this DICOM standard, and if I can see, there it is there. This waveform is one of the different series. You can have an image or a waveform that can be bolted on, but that doesn't allow it to stand in its own right. So the aspects that I want to speak about specifically about some of the research that we've been doing, and I'll need to speed things up. First of all, in the real-time processing space. So we created an environment to define an ontology, to set up some varied clinical rules, to have those rules run on streams for individual patients and have that overseen and managed in real time. And I developed this with a PhD student back in Australia. But one of the challenges that we faced within this environment was that we needed to write a low-level event processing environment to receive all of the individual items that were coming in on these physiological data streams. And when you want to upscale, potentially that represents a challenge to have a production environment for the throughput and complexity that we were looking at of events. So the first of a kind collaboration that I was awarded back in July of 2008 was to work with the IBM TJ Watson Research Centre team on a product that has now been formally launched called System S. And the System S environment is an event stream processing environment. But what we've been able to do with the IBM TJ Watson research team is to build the layer that works above System S that's applying that concept within the critical care space, as opposed to the financial space and some of the other areas that they've been looking at for this. So our project, fortunately, was one of the major drivers that IBM made the strategic decision to take this product from a development environment to a production environment. So it's a bit more about that. And here's another article. This was out of the IBM's brochure on various strategic initiatives with Canadian universities. So I won't dwell on that. So this is some of the team that is now working with me on our research project. It's a range of IBM TJ Watson Research Centre researchers that have been dedicated to the project, some from IBM Canada, and the neonatologist Andrew James, some of my students, and also my colleagues at UOIT and internationally. A very rudimentary high-level diagram. Some of the aspects not shown in this diagram or have not been shown because we're pursuing a patent in this particular area. So you have patients attached or having data collected from a range of different signals and through a range of different devices that is integrated through a data hub and fed into this environment where we have written medically focused rules in a language called SPADE, which is used by System S. So we've created the environment for it then to feed down that information and the rules with the data to this System S environment and then make assessments on whether alarms are being triggered in real time. The data is stored, unlike a lot of other domains for this type of software, we store all of the data. We don't just drop it. We need to, for medical record reasons, we need to keep the information as well. Now, in terms of the analytical processing, that was talking about the front end. What we also need to do now is create the environment once we collect this rich information of physiological data and we know that these babies develop certain conditions in certain points in time or they were diagnosed at a certain point in time with a certain condition. We can use that information to use some new data mining techniques to be able to analyse that information and find common behaviours across streams, across patients that exist before the certain diagnosis. So to use that, I just wanted to revisit the data mining, where it's come from, and the decision support, where it's all come from. So initially, there was some artificial intelligence and machine learning work starting way back prior to 1960. In the 1970s, there was a strategic move to separate programs from data. And then, as I said, when I started in the early 90s, there was this new area of not just having transaction processing systems to support the deposits, the withdrawals, the sales, but to be able to support the analysis of that historically. So that was the data warehousing and then leading on to the data mining. One of the new areas that is currently being researched within the data mining area is what's known as this temporal abstraction-based data mining, which is an area that I'm working in as well, which is trying to look at encoding streams based on their behaviour or even multiple behaviours and doing the data mining based on behaviours between multiple patients. So for those of you that aren't aware with data mining, there's a standard that essentially explains the process that you go through for data mining. So initially you will have this business understanding where you understand the needs of your data mining exercise. So for example, a financial organisation may want to understand the particular patterns and behaviours of customers that ultimately default on their loans. Now, this opens up all sorts of ethical issues about doing that sort of data mining, but it serves as a good example. So that's their initial focus that they want to try and understand. To do that analysis, they have to understand how the data is represented in their warehouse for customers, for information about defaults, to gather the information on how you know these people have, these people haven't, and get your data ready. So you move down then into data preparation, where you prepare for the data mining exercise, and then you go through some modelling and evaluation where you start to analyse and use your data mining techniques, and then ultimately you'll deploy some sort of a solution. So within our context, what we needed to do was not just take these static points of information, but we needed to start to mine streams. So we started to look at the temporal abstraction and data mining trends, and a lot of this turned out to be within the medical context. Whether people were looking at null hypothesis testing, because in medicine for evidence-based practices you need to prove some sort of a null hypothesis-based approach. And how was the knowledge base set up in terms of what they were looking for? And the dimensionality of the data, were they just looking for a particular diagnosis? Were they just trying to watch the ECG stream? Were they just trying to work in real time for a patient? So what types of work was being done? And there were a couple of things that we found. First of all, and of note for us, was that no one was proposing this multi-dimensional environment where it could be data-driven for the type of diagnosis you were looking for, who was in what patient cohort, and what streams were of relevance. No one was proposing that approach. But more alarming for us was that there really wasn't a standard in the way people were reporting their research and reporting their findings in terms of a series of steps of making sure they spoke about how the data was structured, they spoke about the type of technique they used for temporal abstraction, and they actually provided a consistent set of information. So one of the things that we've just... Whoops, wrong way. Why am I going backwards? One of the things that we've just had approval for in publication is an extended approach to CRISP-DM, which we've called CRISP-TDM for temporal data mining, where we propose extensions to this approach when your problem is in this space of temporal data. So what do you need to additionally record for these particular steps? The business understanding, the data understanding, when you're modelling the data and doing your data mining, and more importantly, how that data is being stored. Do you store one row with an array of 1,000 readings? Do you have 1,000 rows in a table? How do you set that up? And also in the deployment. Sorry, I need to move through these slides. So we found a number of things, as I've mentioned these previously, that a lot of the work in data mining in the medical context is used as a prediction based on human-identified interesting patterns. So you're watching patients in real time with known rules to find those interesting patterns. More of what I've already said. One other aspect that I want to touch on briefly is in terms of the holistic approach, you need to understand the way neonatology is working to then be able to create the environment to set the rules within that context, and then to be able to mine the data historically based on diagnosis or some other marker that you're looking for. So going back to my initial structure of my PhD research, I worked with a PhD student in Australia to extend that so that this was something appropriate for healthcare. Because in the healthcare environment you have government legislation, you have clinical practice guidelines, and you also have the needs of the patient. But it's not just a widget that's going through the system. It's not just a loan, it's not just something, a car. It's a real person with cultural needs, with other patient needs. There are guidelines to follow in government policy. So how does that affect what you're doing? A lot of initiatives around the world in terms of re-engineering and modelling a patient's journey utilise this particular diagramming technique. This is called lean thinking. And in this particular technique, the activities that are followed are along here. And when a patient actually comes in physically and out of an area is shown here. The clinical roles involved are here, and the time that it takes and the queuing time until the next activity is shown here. This diagramming technique, though, was developed not for healthcare, but for car manufacture. So we've taken something for car manufacture and put it into this environment. And I'll go through, there's some examples I'll go through in a minute, where this technique does not allow you to model the cultural needs. When is an interpreter required, for example? And how can you put that, other than maybe putting them in as a role, but they're not a permanent role, they're an optional role, then how do you put that in? So this is another, the UML-based technique, again, has a similar site with shortfalls. You can't model these things that we need to in healthcare, but they're used. This is a modelling technique that we worked on, that we're continuing to research on. It's called it's patient journey modelling, PJM, so we called it pyjamas, because, you know, patients often are wearing pyjamas. So in this in this instance, it's a midwifery example where there's a woman presenting. And what they're trying to work out, we were working with a midwifery-led care unit in an Australian hospital, and it moved to a midwifery model because the only obstetric anaesthetist pulled out of the hospital, and they were going to have to close that whole ward altogether. But they changed it to test a model of midwifery-led birthing. One of the things they have to do is assess whether or not a woman is able to go through this if she's low enough risk. One of the things that came out when we modelled their particular journey was that they found out that they spoke to the woman 3 times. They had a number of different activities that went over 7 to 10 days. And in actual fact, the very next activity was the one when she was finally asked questions that would work out whether or not she was low enough risk. So they'd actually gone through and shown her the wards and shown her the environment and introduced her to some of the team, and then they sat her down and said, all right, let's have a look at your history. And then they'd say, no, I'm sorry, you can't birth here. You're not low enough risk. So our technique was able to show them that. And the way, so you have the same different activities going through here, what information is used in each step or generated, and whether it's paper or a system or the inevitable whiteboards that we always find that have the most critical information on them, and what policies are in place, what metrics exist, and in fact in our later iterations of this we also have the information on patient needs as well. So this is another one that we completed within the Northern Territory in Australia. It's part of a initiative for 1 + 1 = a healthy start to life, so the year before birth, and the year after birth. The previous clinical practice was that any woman in the Northern Territory who was pregnant was taken from her Aboriginal community or her Anglo-Saxon community and taken out at 37 weeks gestation and either put up in a hostel in town, which was Darwin, or put up in a hotel if she could afford that. There was these vertical lines here means a complete care disconnect. There was absolutely no handover. So this team here didn't speak to the hostel other than that a booking was made. There was no handover. This often late teenage Aboriginal girl was then attended to in an antenatal appointment. You can see all these different colours of the people, and the fact that the colours, other than the poor person, keep changing all the time. When she goes into labour, whoever the midwife were on duty would assist her, or a team of midwives would work. Again, no handover across the way. And when they went back to their community, again, nothing. Not surprising that the girls would run away and the women would run away and they'd run back home because they were absolutely terrified. No communication, no one went with them, there wasn't money to send anyone with them unless they could fund it themselves. And we were really able to show to the government in terms of policy that this is what you were doing now. And one of the interesting things, and I'm near the end of my presentation, so I just want to go over this example. One of the people on this team to help us build this model was a female elder, quite a well-respected female elder in one of the Aboriginal communities. And my PhD student was collecting this information, and the whole time this elder was sitting in the back with her head down, and she honestly thought she was asleep. Came back the next day, and same sort of behaviour in the meeting environment. This particular model was presented. And then at the end of it, I said, are there any questions? And all of a sudden from the back, this charming Aboriginal elder said, "You, girly, you've got it wrong." Well, I think she nearly fell over, but was able to compose herself enough to say, "Why? What's wrong?" She said, "The woman, she's not black and she's not pregnant." Now let's take a step back from that scenario for a minute. This is a lady who has never seen a computer, never had any interaction with information systems and any technology. She'd been able to take this technique and understand because she understood what was happening to her people. She could see it. But the biggest thing that she didn't like was the fact that the woman was red and she wasn't pregnant. So Joanne quickly took it off screen, changed it all around, and that was solved. But that's the type of impact you can have when you use a modelling technique that's right for people and isn't something for car manufacturing. So I'm just going to quickly move through these. It's just an example showing the disconnects. I forgot these extra loops were in. So what's being developed now as part of government policy is a change, so that these dashed lines mean that there is a care handover, that these midwives now work in teams, and someone from the team makes the initial visit and is part of the town visit. Someone from the team organises the hospital orientation, or as many from the team, and women from that same team are involved in the labour and birth. So this is how these modelling techniques can help to drive or help to provide the diagramming technique for policy change. Sorry, I'm just going to move through these. Okay, one of the other things that we're doing is we're using this same approach. We've developed a means to use an online collection asking people questions within the neonatal care environment, and by doing that, understand within that plethora of roles how they're exchanging information in the neonatal unit, and from the data that we collect in the database from that online survey, generate these models. So we're working on that with the Canadian Neonatal Network. My unit, just briefly now, the Health Informatics research that I've been able to bring together at the university, we have been able to establish a very unique, internationally unique laboratory where we have a number of medical devices that are dedicated for our research that we can leave running in demonstration mode. We haven't attached them to people. We can leave them running in demonstration mode. We have test neonatal lungs so that we can have our ventilators running in a simulation mode as well. So we provide students and our collaborative partners at IBM with the opportunity to be able to collect data and understand the formats of the data and have it running to do our system capacity testing, all within our laboratory. We can use a series of switches to simulate the equipment being in a remote setting or a local setting and create that very interactive environment. And it's proved to be very successful to have this equipment available for computing science and engineering-based research. So these are some of the devices that we have in our laboratory. So this is the Philips IntelliView series monitor. So this is the one that monitors the blood pressure and respiratory rate, range of other things. This is the Dragar ventilator, Babylog 8000, and this is a test lung sitting on the bench here, a neonatal test lung that we can attach it to. Another shot of our laboratory and the graduate student area within the laboratory as well. We're working now to upscale our capacity so that we can have data collection from every bed at the Hospital of Sick Children and IWK Health Centre in Halifax. We are implementing our first bed online in June, and we're going to do some initial testing for the first few months. We'll be bringing IWK online next year. And we have a number of grants out for adding additional components within our laboratory as well. So our collaborative partners, Carleton University, Dalhousie, the Canadian Neonatal Network, IBM Canada, Sick Kids, as you can see here. Patient journey modelling work we've also done with mental health or Whitby Mental Health Centre. In Australia, I'm collaborating still with the neonatal unit at Nepean Hospital in New South Wales, and the work with the Aboriginal communities is with Charles Darwin and also the Cooperative Research Centre for Aboriginal Health. Internationally, we're working with the University of Aberdeen with the NIC unit, that's that 80-bed NIC unit in women and infants in Providence in Rhode Island, and also IBM TJ Watson. The university where I'm located now, you may not have heard of. We are now almost 6 years old. University of Ontario Institute of Technology. Here's some of our shots of our buildings. We have, incidentally, the largest geothermal core in all of Canada, second largest in North America. So all of our buildings are naturally cooled in the summer and naturally heated in the winter by passing the air through this geothermal core. We are building at the moment this extension to our engineering building, which will house the largest wind tunnel in all of North America. We'll be able to test up to the size of a bus and do weather tests from +40 to -40 in this environment. And though we have hypothesised about putting an ambulance in that environment with a NIC in it, we haven't done that yet. We are a laptop-based university. Our mandate is to be highly technical. If I was delivering this lecture to a group of students, they'd have a Tim Hortons cup and a laptop. The laptop, at least, is supplied by the university. Now, I just wanted to switch tacks. That ends the discussion about my particular research mandate. So we are moving from traditional charting to a new area of uncharted discovery. And I'm very passionate about making a change to save lives. So I just wanted to briefly say in my role for engineering and medicine and biology, the maple leaves show where there are sections of IEEE in Canada. The stars here are where there are engineering and medicine and biology chapters. So there is a chapter of engineering and medicine and biology here in Kitchener-Waterloo. Where I've colour-coded them now in purple, there is also a women in engineering presence as part of IEEE. So you have that here as well at Kitchener-Waterloo. Engineering and Medicine and Biology Society is not just, actually I'll go back, it's not just for engineers. They have opened their mandate for a number of years to welcome clinicians, anyone who has an interest from whatever perspective you come to in the use of engineering and technology in medicine and biology. There are internationally approximately 8,500 members. It's the largest engineering-based biomedical society in the world. And women in engineering, interestingly, not just associated with engineering, medicine, biology, but women in engineering is about 10,000 members worldwide. So I am, as I said, I am the Canadian representative on the Administrative Committee for Engineering and Medicine Biology, and they're representative to women in engineering. So if anyone has any feedback, if you're interested in engineering and medicine biology, and how you can connect with people, how you can utilise the mentoring facilities that are available through IEEE. For those in the room, for those of you that are connecting remotely, you can always email me and I can try and send you some information. But we have some of the magazines for the Engineering and Medicine and Biology Society. Women in Engineering's magazine, coming out in June, will feature Engineering for Humanity, and I was actually interviewed for that particular magazine as well. So I encourage you, if you know that there is a section, if you're interested in the use of engineering in medicine and biology from whatever perspective you come from, I'd encourage you to join that. So thank you for the opportunity today.
Well, thank you for that very interesting presentation, and so many different aspects of your research I find fascinating. And so I have so many questions, but I'm sure that our audience does as well. So I invite the audience to let us know if you've got a question, and I will get a mic to you, and as well from our website as well. So any questions from the audience? I guess I should stand away. We have one from the website.
I have one from Dominic. In one of your earlier slides, also repeated near the end, you had something about workflow audit near the bottom. What did this audit refer to, i.e., what was involved?
Okay. I may set the slide system into disarray, but I will try and go to the slide. Essentially, I can answer while I'm trying to find it. Essentially, when you are trying to set up the initial environment, you define your organisational strategy. You also define the processes that your organisation is going to carry out within a healthcare context that is looking at the patient journeys that are going to occur. So you're going to design those on a generic level. But at some point, you start to enact those in reality. There starts to be individual instances of sales, of individual patient journeys, and you're trying to collect the information for that individual instance as opposed to just creating the model of the concept. So when we spoke about audit on those particular slides, there it is there. Oh, no, the wrong one. So when I spoke about the auditing, it was really referring to that mechanism of storing the information of that particular instance of a particular journey. And so you may think of it as an audit log or a transaction log.
While we're getting a mic to one of our people in the audience, I'm interested to know whether this particular research that you're doing in neonatal, the neonatal area, whether you see that it can be applied to other areas in critical health.
Definitely. One of the nice things that about working with neonatology is that it is a population health-based problem. By that I mean that if you have a baby who doesn't have any congenital abnormalities, so for example, if it's not complicated by Down syndrome, trisomy 13, some other particular congenital condition, and if all that has happened that for some reason they were born at 24 weeks gestation, then their organs are going to be about the same level of development as another baby born at 24 weeks gestation and not having congenital abnormalities. It's just that they were born at that particular point in time. So it presents a very nice population health-based environment that you can start to extrapolate certain things, certain trajectories of care based on that. So adult cardiac patients, when you're trying to recover from cardiac surgery, or other particular care protocols in that instance where it's a population health-based problem, then this would naturally apply. If it was an emergency department ICU and you had someone who'd come in with a severed arm, someone who'd come in from a gunshot wound, someone who'd come in from a fall from a building, you've got very different individual cases, people with a number of different clinical backgrounds and issues. And you could still apply some rudimentary observations on the cardiac system, respiratory system, and the brain, but not in the same, you won't get as much benefit as when you look at a population health model.
But perhaps something like an area such as cardiac might be a transfer area, a similar area to apply, but maybe more complicated.
Yeah, so the question was in terms of cardiac, would that be a similar area? Yes, it is. In some area, to some degree, it's actually less complex in an adult than in a child because you have immature organs in a child presenting with different conditions. But yes, it can apply to that.
Thank you very much for your talk. It was very interesting. About the workflow audits, you mentioned that it was basically logs of more specific kind of than the general workflow model, mm-hmm. So they were sort of cases. Mm-hmm. How were you using those? Were you referring back to those cases later where people would refer to how that workflow proceeded so that they would maybe enact a similar workflow in the future? Or how were they used?
Predominantly, I'm still trying to go back to that slide. That information, there we go. So this is the audit log here that we're talking about. So this information is used in a clinical setting. This audit log can actually be the physiological streams coming through. It can also be the admission information for a patient and other clinical information that's collected. So essentially, within this medical and healthcare context, you're creating an environment where you can store this information to have real-time processing for that particular patient, but also use it later on for data mining, for population-based research if you're trying to look at number of people presenting with a certain condition, if it's outside an ICU, if it's in an ER, you've got a certain number of people who are presenting with this sort of condition that they're needing to go into critical care or not, and you can start to watch for certain disease breakouts or just behaviours in populations.
Further on that, there's a gentleman by the name of Van der Alst in the Netherlands who does process mining in healthcare, the PROM framework. Maybe
Yeah.
find that interesting.
Yeah, no, Van der Ast has been very successful in his research within and outside healthcare in the business process modelling space. He's been quite a leader in that area, but they haven't really focused on the critical care informatics, which has really been more of my focus.
There's a question oh, I'm sorry. Yes, please go ahead.
I have a question regarding your indicators. Do you have different indicators for male and female children? And do you use the mom's medical history as an indicator?
It's actually a very interesting question. At the moment we don't, but we are aware that by and large female neonates are stronger and have better survival and morbidity outcomes or reduced issues in morbidity than males. That is a reality of the statistics. At the moment we don't have that, but what this environment will allow us to do is to start doing the data mining. When we're collecting all of this physiological data, we are going to be collecting gender, so we can start to extrapolate and look at the different behaviours, and that is definitely an area of interest because it is known the differences in survival with boys and girls. And in terms of the mother's health indication, in our initial work, we're not putting that on the table, but it is something that this is a journey in the sense that we're trying to show this is a valuable environment to create the environment that you have separate research questions that you can run against the environment. And I certainly think in the case of neonatology, enriching it with parental history is a valuable project, and it is something that actually the Rhode Island group is looking at as well.
I work in cardiac, and one of our indicators is the history.
Yes.
Because at least 95% of our patients are smokers or ex-smokers.
Yes.
And that is a big indicator for us. So we do look at those kind of things.
That's right. And with an adult patient with a history, that definitely becomes more relevant. What we've found, and in our discussions with neonatologists, is we often with neonates, allergies is not as much of a concern, and smoking obviously not as much of a concern. Within the neonate themselves, there may be some withdrawal because of the mother, but it's not.
Would maybe cause a problem with that, with the
With
mother.
alcohol,
That's why
yes.
I wondered about the mother's history.
And drugs as well.
Yeah.
Yep. Thank you.
There's a question in the back here.
A comment from one of our viewers. No matter how good the data streams are, data without having the patient in front of you, it will be difficult to practice good medicine, let alone clinical acumen.
Oh, definitely. And this is a support tool and a support environment. And I mean, the remote clinician can be a support person for a resident on site. And also, with any sort of remote model, we've always worked on the approach that there is a video stream that they can see the patient. But it is definitely something to look at in terms of behaviour and clinical practice, this whole paradigm of what type of support can be provided remotely. And it is something that I'm very aware of, that we have to be very careful in looking at support models when they're in a remote setting.
From Dominic, what is interesting to me is that the degree to which your work parallels the work of Bill Stead at Vanderbilt. I hope that you have a chance to view his presentation. It's on our website. And Dominic would like to get the two of you in contact with each other.
Great.
Note, Dr. Stead's work is with patients on respirators.
Mm-hmm. Great. Thank you. I'd like to do that very much. Thanks, Dominic.
With respect to workflow modeling, you mentioned changing contexts. Have you made an effort to model context with respect to workflow in some way, perhaps ontology modeling?
Which type of context are you speaking about? The
Physical,
care pathway?
clinical context.
Yeah, there's definitely a different journey that a baby that's born at 23 weeks gestation takes to a baby born at 27 weeks, even 4 weeks into the 23 weeks journey. They are a different baby when they get to 27 weeks. So yes, we've been looking at and this issue of trying to model this environment is something that we've been looking at.
I was wondering if whether there would be the need or the possibility of modeling, say, the mothers and the neonates in our northern communities, like you did in the last few charts or slides that you showed us, and whether we might see some disconnects that we could improve upon in our process and procedures.
There has been some work, interestingly, by the two of the women that were involved in the Australian study in the Northern Territory had been doing some work in Canada, and for those particular women, the work that they'd done completed in Canada in the northern areas, they were finding similar issues.
Are there any other questions?
Hi. I think you're asking clinicians to practice a little bit differently when you use your environment here. And how has buy-in been? Because they need to buy in, and you obviously have some champions, some doctors that are really pushing it forward. But in the general community, how are things looking?
Overall, within the general community, I gave a very similar presentation to this to the Department of Paediatrics within U of T, which looks after 3 NIC units within the City of Toronto. And broadly, because they all had to fill in evaluation sheets, and I would probably say from the response from those, and there was about 35 to 40 people in the room, that 80% of those people in their reviews were very supportive of the work, saw that it had potential. Some wanted to were looking forward to see what it could demonstrate, and there were those that raised concern. But interestingly, a large portion see that analysing and seeing all of this data is an enormous challenge for them. So the fact that we're working on this, but more importantly, it's extremely collaborative with the neonatologists, and we are very much looking at their work practices and engaging them in the process. And that's something that's been very important to me in a background of computing science. And I take it as a compliment when I give presentations and people afterwards make a comment to me and say, oh, I thought that you were a neonatologist. I didn't realise you were a computing scientist. And I take that as a compliment because I've really tried to understand, and I continue to try and understand the environment.
I think there's a comment from, one more question here and then a final comment at the back.
A very quick question, just out of curiosity. What's the precision and recall during your temporal data mining? Because when you do evaluation, what's your precision and recall current?
Well, because this is a very new area and we're just starting to gather the data that we need to do our data mining with any depth and number of patients, that is still something that we are trying to establish. Because we can demonstrate the techniques on a very small population set. There's some data that I'm working on from Australia to support a clinical study in Australia, but there are only 50 patients. And not all of those 50 patients developed the certain diagnosis that we were looking for. So we can demonstrate that the techniques work in principle, but we are looking forward to much greater data sets that we're going to have in the next 6 months to really explore it further.
Well.
That's right.
It's for sure. Yeah. Thanks.
Thank you.
We have a last comment from the web, I believe.
This is from Dominic.
Hi, Dominic.
I heard that the wind tunnel is linked up to the lecture halls at UOIT. Is this just a false rumor?
Well, I don't know about it being connected up to a lecture theatre, but I know that there are going to be academic offices nearby, of which I won't have one. But we have been contemplating a research project of putting a transport deck that goes into an ambulance, in the shaker room, and collecting data while it's shaking. So, something we're contemplating. But no, we're not going to blast our students if they sit and aren't paying attention in class.
Well, I'd like to thank Carolyn for joining us today and her very interesting presentation. It's been so interesting, and your research is fascinating. The areas that it's covered, right from designing the hardware right through the workflow, interaction, all the human factors and interaction with the clinicians, to the data mining and analysis. It's just fascinating. So thank you for giving us your research overview today and where you're moving towards. It's such a valuable area for us. If we have healthy babies and then we'll have healthy adults, hopefully, and everybody will benefit from that. So thank you. And may we all thank Carolyn for her presentation today. And I'd like to give you a small token of appreciation for coming to us today. So thank you very much, and I hope you come back on June 24th. It will be the last seminar in our series, and we'll take a break over the summer. So please come back and join us for one last time.